For those of you who are still wondering, my name is Pradeep Chopra. I'm a pain medicine specialist, and I've been tasked with the job of explaining neuropathic pain to you. Trust me, it wasn't easy. It's probably one of the hardest presentations I've ever made. But anyway, I'm going to try my best. Dr. Henderson did a fabulous job of talking about some of the central nervous system issues that'll segue right into my talk. So I'm going to be talking a lot about off-label use of medicines, and this is the standard disclaimer. None of this is to be taken as medical advice. This is a disclosure. I'm a pain medicine specialist. As I said, I have a special interest in complex pain conditions. Trained in pain medicine. I now work as an assistant professor at Brown Medical School. So I'm just going to briefly go over types of pain. How much time do we have?
So you're good.
Okay. I have a timer here. All right. I tend to overshoot. So anyway, types of pain. Just a basic outline of types of pain. There are really just three types of pain. One is nerve pain, whereas it's called neuropathic pain, and that's going to be our talk today. This is pain as a result of nerve damage. And then we have structural pain, which is called nociceptive pain. Like standard pain. You break a bone, that's nociceptive pain. You have arthritis, that's nociceptive pain. Most of us, those who have chronic pain, are mixed pain. So they have both structural and nerve pain. And that's the most common type of pain. And the difference being that somebody might have more of structural pain and less of nerve pain. So there might be more structural, less nerve pain, or somebody might have more nerve pain and less structural pain. But essentially, almost everybody has both. There are exceptions, though. So let's talk about neuropathic pain. This is just the nervous system. So the brain and the spinal cord are called the central nervous system, and then you have the peripheral nerves. That's the rest of the nerves that go to your body. And then there's another nervous system, a hidden nervous system. Did this die?
I don't think it died. That figures.
Are you guys? Am I getting hints over here or something? Hello, can you hear me? Okay.
Yeah, okay.
Can you hear me?
It should be on.
Yeah, they can hear me.
Good?
Yeah,
All right.
I can shout. Anyway, so there's another nervous system, a hidden nervous system, called the autonomic nervous system, and that's a mean nervous system if it goes bad, and that's what this whole conference is about. That controls the automatic functions like vision, breathing, movement of the intestines, or also known as a fight and flight. It's essentially, when God created us, did not trust us with these functions. And so I don't trust you to breathe on time. I don't trust you to be able to focus. So put that as an automatic function. Now, neuropathy or neuropathic pain can affect any of these. And Dr. Henderson really put it nicely on the brain and the spinal cord, how that can cause neuropathic pain. The difference is in structural pain, it's more inflammation. There is structural damage. So somebody has an arthritis, so the joint is damaged, the cartilage is damaged, but it's more from inflammation. Whereas in neuropathic pain, it's more from nerve damage. The nerve is damaged, partially or fully is damaged. And there are many ways they can be damaged. We'll talk about that. It's really important to understand what's the cause of the pain. Is it inflammation or is it actual damage? And that decides the treatment. So some of the there's a huge list of causes of neuropathic pain. I just picked up a few common ones. But there's post-herpetic neuralgia, so pain after shingles, trigeminal neuralgia, that's this intense pain in the face, diabetic neuropathy, Sjogren's syndrome, lupus. This is radiculopathy, which is pain from the spine going down your arm or your legs. Trauma, infection, and stroke. Stroke is a different animal by itself. It's called central pain syndrome. It's a whole different. This actually affects the central nervous system after a stroke. Now, this is a concept I really need you to understand: central sensitization. This applies to almost every chronic pain patient. Almost every. So, I'll give you an example. If I take a pen and I stick it in my finger, there's a signal that goes up my arm into my brain, and my brain then reads it, and then it passes it it does things. I yell, I scream, I pull the pin out, my pain is better, the signals stop, and I'm all set. That's acute pain. When I stick a pin constantly for days and days and weeks, if I stick a pin, there's a barrage of signals going up my brain and down, back again. The brain is trying to suppress those signals. So these signals are traveling up and down. And that sensitizes the central nervous system. And that's called central sensitization. Which means that any other trauma that I have, or if I have pain in my right arm or my right leg, that gets dialed up. So a normal sensation, for example, touch produces an abnormal response. And that's like when you touch somebody in neuropathic pain, when you touch them, they feel this really bad, painful touch or a creepy, crawly sensation. So this is from the Smithsonian. But it's going to the Smithsonian. They just called. But anyway, this is the brain and the spinal cord. Nothing like Dr. Henderson's pictures, but anyway, this is the brain and this is the spinal cord. And these are the nerves that come out from the spinal cord. What happens is, if one of those nerves starts to get inflamed, or one of those nerves start passing signals, that nerve, so this is the nerve passing the signal up. It passes it up to the brain and the spinal cord. And there's a barrage of, so the brain in turn sends signals down, and so there's a barrage of signals going up and down. Essentially, this whole nervous system gets sensitized, which means that all of these nerves start to hurt. And that is the phenomenon called central sensitization. It won't hurt, this will not hurt as much as this, but it's still very sensitive. So one of the topics I want to talk to you about today was about small fiber neuropathy, which comes up a lot. Now the spinal cord looks like imagine the spinal cord looks like the roots of a tree. So they're thickest in the middle, and then as they branch out, they become thinner and thinner. And it's the same thing with the spinal cord. It's thickest in the middle in the spine, and then as they branch down, they become thinner and thinner. Essentially, the nerves in your fingers and in the toes are the thinnest. And it's those thin nerves, the weakest nerves, are the ones that get affected first. So the smallest nerves are damaged first. The ones that are furthest away, so the toes and the fingers, are the ones that get damaged first. And this is called stocking and glove distribution. Usually it starts in the toes, not in the hands as much. It starts in the toes, and it slowly starts to go up the leg. Rarely will it go above the knee, but usually stops right there. In some severe cases, they start to develop it in the hands also. That's the classical phenomenon of small fiber neuropathy. I'm sorry, these sensory functions, these fibers usually carry temperature, sensation, and touch. They also affect the autonomic nervous system. Remember the hereditary nervous system I talked about that controls automatic functions? It affects those nerves also. And that's one of the reasons for dysautonomia. Not the only cause, but it's one of the reasons for having dysautonomia. So these patients present with decreased thermal sensation, again in the glove and stocking distribution, mostly in the stocking distribution. There's decreased pinprick sensation, numbness, pain. It's called dysesthesia. It's a very creepy, crawly sensation. They kind of withdraw their hand. It's not pain as such, but it's a bad sensation. Or it could be a combination of any of these. They complain of burning feet, pain to touch. They feel their feet feel like wood. They don't have that sensation. They don't have that control, and it also feels like they're walking on pebbles. If you ask a diabetic neuropathy, they'll know exactly what I'm talking about. Now, the autonomic nervous system controls all the automatic functions we talked about: bladder, blood pressure, sweating, heart rate, breathing, movement of the intestines. So if the autonomic nervous system gets affected, all of these or some of these can get affected. Some of the symptoms they produce are dry mouth and dry eyes. Now, there are certain other conditions like Sjogren's syndrome will also present in the same way. So you really have to rule that out first. It slows down the intestines, which is gastroparesis or dysmotility. They alternate between diarrhea and constipation. They have nausea, dizziness, and fainting, and a feeling of anxiety. It's not a true anxiety. It's a feeling of anxiety where your heart rate goes up as soon as you stand up. You're not really anxious from the brain, but it's from your body. They have increased sweating, especially at night or with eating, fatigue, and increased urinary frequency. Now, these may not all be there, but some of them are usually present in autonomic neuropathy. And Dr. Henderson had shown the whole list of symptoms of autonomic neuropathy. One of the theories is that why do these small fibers get affected so much? And the commonest reason is actually glucose metabolism, not diabetes. I mean, of course, diabetes, but they're now saying that anything that affects the metabolism of the glucose can affect these small fibers. So even a mild abnormality in glucose metabolism is at risk for developing small fiber neuropathy. So the most common cause of small fiber neuropathy is actually idiopathic. We don't know. And there have been many, many theories. Is it heavy metal poisoning? Is it, is it diabetes? Is it one of the other immune conditions? Usually testing is normal, and they don't find a cause. Lately, they've been talking a lot about viral infections. So if somebody had a minor viral infection or just a cold or some kind of a viral infection, their immune system goes haywire, they develop neuropathy. Mast cell activation syndrome, I believe somebody's going to talk about mast cell activation syndrome in more detail, so I'll just touch on it briefly. Mast cells are generally normal cells that are normally found in the human body. They remain inactive. They're like the National Guard. They remain inactive when they see a trigger. When they see a trigger, they get activated, and when they get activated, they release all kinds of nasty chemicals like histamine and cytokines and tryptase. The problem in people with mast cell activation syndrome is that they trigger easily. We don't know why they trigger easily. We are still puzzled over that. But they do trigger easily. The release of histamine and tryptase leads to a release of this chemical called calcitonin-related gene peptide, CGRP. And the reason I put that is there because I'm going to talk a little bit more about it. There's some exciting news on this. And they produce this chemical called substance P. It's a peptide. These chemicals cause inflammation of the nerves. So we have mast cells get activated. They produce histamine and tryptase, which lead to release of CGRP and substance P that causes inflammation of the nerves. Inflammation of the nerves themselves cause release of CGRP. You guys keep feeling neglected? No one's watching that. Okay, so I'll just stay here. I'll briefly touch on the treatment of mast cell activation syndrome. There are 3 parts to it. The first part is antihistamines, ranitidine, I like clemastine. You can take Zyrtec, Benadryl, whatever you like. Clemastine is a really old antihistamine. The reason I like it is because it also helps with pain. It's technically supposed to be over the counter, but it's easier to get it with a prescription. So that's the first part, but then you need to stabilize the mast cells, and these are some of the drugs that can be used: ketotifen, cromolyn, and quercetin. Quercetin is over the counter. And then, of course, the most important one is to find the trigger. Is there something that you're eating, or is there something that you're breathing or applying? These are the 3 ways you can get a trigger. So you have to look into your foods, or if there's anything in the house that I can go on and on, but you can breathe. So it could be something that you're breathing, or if it's something in the foods. So the problem with structural pain, so we talked about structural pain and neuropathic pain. The problem with having mixed pain is that structural pain may not be as difficult to treat, but it can trigger neuropathic pain. So, for example, as Dr. Henderson talked about the spinal cord, and he talked about craniocervical instability, it's a structural issue, it's craniocervical instability, but it then leads on to neuropathic pain. You can't treat the neuropathic pain unless you treat the structural issues there. So there's overstretching of the nerves, there's compression of the nerves that have to be looked into. And unless we don't treat this overstretching or the compression of the nerves, we're not going to be able to treat neuropathic pain. This is Chiari malformation. We've already talked about it. I'm going to touch on it briefly. This is the cerebellum. This is the normal brain. This is the cerebellum. This is when the cerebellum starts to poke through the hole in the bottom of the skull called the foramen magnum. The brainstem pokes through it. Everything gets really tight. And then, of course, there are the angular changes that happen in EDS especially. Uh, so these are the symptoms of Chiari malformation. I'm going to skip over them, but you can see that there's numbness or paresthesias to the paresthesia means tingling and numbness. To the arms and legs, there's weakness, there's dizziness, vision problems, something similar to having dysautonomia. Now, craniocervical instability, the neck is stabilized by ligaments. This is a fine collection of ligaments that support our head on a very delicate neck. Anything that goes wrong with the ligaments, as in Ehlers-Danlos syndrome, these ligaments overstretch. It can't support the head as much. It can't support the spine as much. So excessive movement of these joints can affect the nerves from the spinal cord, and it can even affect the spinal cord. I've kind of divided it into two parts: upper cervical CO to C2 and C3 to C7. The symptoms are slightly different. In the upper cervical instability, you'll see more neurological symptoms, nerve symptoms like dizziness, paresthesias to the face, ringing in your ears, poor sleep, poor vision, anxiety. So these are more dysautonomic symptoms that you'll see in the upper cervical. In the lower cervical, it's more muscle spasms, neck pain, and tingling and numbness in the hands. In mild to moderate cases, you can start with physical therapy, strengthening the neck muscles to give it enough support. And then you can go in for the hard cervical collar, and eventually in severe instability, it's cervical fusion. Tethered cord is another example of nerves being overstretched. And I think Dr. Klinger is going to be talking about that tomorrow a lot more. But basically, the spinal cord over here ends at the normal spinal cord. This is the normal, and this is the tethered spine. So the normal spinal cord ends at L1, and there's this little tail that hangs freely in there. It's called the phylum that hangs over there freely. In tethered cord, what happens is the phylum is connected, is thickened over here. It's attached to the bottom of the spine, so it pulls the entire spinal cord down. So in this case, it's from L1 down to L3, and that's stretching of the spinal cord. There's stretching of the nerves over here, and that's the one I talked to you about, how people develop neuropathic pain from stretching of nerves. So the spinal cord is literally taut between the skull and the lower spine. This pulls on most nerves exiting the spinal cord, including the spinal cord itself. They present with back pain. Most people have back pain, but this is kind of a different back pain, not easily explained by MRIs. They have pain, weakness, spasms to both legs, and it affects their bladder, called the neurogenic bladder. This is another one that that's just sort of, every time I think that I know all about EDS, something new comes up. Seriously. Every year there's something new. No one had heard about mast cell till about a few years ago, and now all of a sudden we have mast cell activation showing up. And so now we're starting to see patients with something called abdominal pain, and it's called median arcuate ligament syndrome. I can't tell you how common it is. We do see it in a fair number of our patients, but not all of them. And I'll explain to you what it is. These patients present with belly pain. It's pretty intense belly pain. It's not like a dull, bloaty belly pain, but it's more like a sharp nerve kind of pain. The pain increases with eating. They have nausea. They get lethargic after eating a meal. The pain increases with exercise or any physical activity. And there are certain postures that make the pain worse. So oftentimes just lying on one side or the other will make it worse. So what happens in median arcuate ligament syndrome, or also known as MALS? This is a big blood vessel that's in the back of our abdomen, and there's this artery called the celiac artery that pokes out, and it provides blood to the intestines over here. And there's a ligament over here. It actually pokes, this picture is not correct, it pokes under the ligament over here. In median arcuate ligament syndrome, or MALS, this ligament gets tightened up. When it tightens up, it squeezes this blood vessel over here. The problem is that when you eat, blood flow to the intestines increases, and if it gets squeezed over here in males, the blood flow cannot compensate for the demand. And so these patients develop pain after eating. The other problem is that there is a nerve over here. There's a set of nerves that they're wrapped around this artery called the celiac ganglia that also go to the intestines. And so we have two things that get compressed. We have the artery that gets compressed, and then we have the nerve that gets compressed. And this is where surgeons will differ a little bit. There are some who believe it is purely a compression of the artery, and then there are some who believe it's both compression of the artery and the nerve. This is you can do there are certain specific MRIs and CAT scans that you can do and look at the blood flow. Eventually, the treatment is surgical, and that's where the surgeons again differ. Some surgeons will go in there and release the median arcuate ligament and let it alone, and some will go in there and actually remove the nerve also. So this was another example of neuropathic pain to the abdomen. Another example of neuropathic pain to the upper extremity I picked out is thoracic outlet syndrome. It's not rare, it's very common. I would say at least 70% of patients with EDS that I see present with these symptoms to different degrees. Usually the pain is, it goes into the shoulder blade over here, and then it goes down the arm, and it goes all the way down to the arm, and it may go to either of the fingers, depending on which nerve is being compressed. What happens here is that there's a space between the first rib and the collarbone. And between this space, you have a bunch of nerves that come out from the neck and go all the way down to the arm. Along with these nerves, there's a bunch of blood vessels also, veins and arteries that go down to the arm. In patients with laxity of the joints, so if they have laxity of the collarbone or they have laxity of the shoulder joint, this space between the first rib and the collarbone shrinks. It becomes smaller. When it becomes smaller, it compresses either one of those three structures. It may compress the nerve, artery, or the vein. And these patients present with pain going down the arm. Oftentimes, this muscle over here, called the pec minor, also goes into a spasm, and that can also squeeze some of these nerves. And this is thoracic outlet syndrome. Classically, patients have pain going down from their shoulder into their arm, and then there are certain physical tests that doctors can do in their office. It'll give you an idea whether it is present or not. The first treatment is to do thoracic outlet exercises. Kinesiotaping does make some difference. Eventually, they can do Botox injections. So they go in there and they Botox these muscles in between the rib and the collarbone to kind of open it up. If all else fails, you have to do a surgical correction, and that varies. They could do a excision of the first rib or something. The results are really good. This is another example of pain in the leg, the tibiofibular joint. These are not rare. These are common conditions that we see. Patients present with pain in their lower leg, goes up to the knee. They usually have knee pain, especially with squatting. And sometimes, not often, it goes up into the thigh. And they have foot drop. There are two kinds of foot drop. There's foot drop that's really very obvious, and then there's foot drop that they develop after some time, after they've been walking for some time. Classically, these patients, when they walk, they sort of scrape their foot on the carpet, or they sort of trip on their toes. Pain on the side of the knee that goes down the leg, that's the classical presentation. There's a nerve over here. There's a nerve by the side of the knee. So this is the knee joint. There's a nerve that winds around, that goes down the leg. It's called the peroneal nerve. And this nerve is responsible for lifting our foot as we walk. So it clears the ground as you walk. In joint hypermobility, we see this in joint hypermobility or in athletes who damage this joint, this nerve gets pinched. When this nerve gets pinched, they present with symptoms of pain down the leg with foot drop. Complex institutional pain syndrome, this is a brutal condition. It's like one of the worst pains known to mankind. Uh, it starts in one limb, but it can start in the trunk. It's a constant pain. It never ever goes down to zero, never. And then they have spontaneous exacerbations. They have a temperature difference between the two limbs. There's a color difference between the two. There's swelling. And then there's the area of pain is much larger than the primary injury. So for example, if I sprain my wrist, the pain is not limited to my wrist. It eventually goes up to my arm. And then in more severe cases, it can go down to the other arm. And this is, again, part of central sensitization. So they have pain or uncomfortable sensation to touch. Nails grow differently. They break easily. They are faster. They are distorted. There's hair growth changes. The hair is coarser, darker. It starts to fall off. Skin changes. Skin becomes thin and shiny. This is only in the initial stages, and they have increased sweating. One of the common thoughts is that this is a type of autonomic neuropathy, but we're not quite sure right now. I think it's more centrally mediated pain than peripherally mediated pain. This is what it looks like. This is the color change that I'm trying to show you. And you can see the swelling. So over here you can see the bones of the hand, and here you can't. So there's swelling over here, and there's a color change. This one, there's a temperature change. This foot was actually 88 degrees. This is 94 degrees. There's a color change over here, and then you can see the swelling from the lining of the socks. So how do we manage neuropathic pain? That's where I struggle the most, because the problem with managing neuropathic pain is you have to fix what's broken. If you don't fix what's broken, then you're not going to move forward with it. Everything else is just a cover-up. All right, so management of neuropathic pain. So the literature is all over about high blood sugar. Control your blood sugar, control your blood sugar. So I put it there. I'm not sure how relevant this is to us, unless we are in the pre-diabetic stage or we or actually have diabetes. Then, of course, it's essential to control the blood sugar. Mast cell activation syndrome. Obviously, if you have it from mast cell activation syndrome, control that. Autoimmune dysfunction, or fix any structural issues that cause nerve compression or stretching. I just showed you a few examples of nerve compression and stretching, or spinal cord stretching also. Some of the medications to try, and this is my experience, so this is 20 years of treating pain, I can give you my experiences. Pregabalin, sold as Lyrica, is worth trying. It works very fast. It's a pretty efficient drug. Gabapentin takes a while to kick in. It's cheaper. It's worth trying this drug. But if you have a choice, I would go with pregabalin. It's a better drug in how it works. Amitriptyline and nortriptyline, in low doses, very low doses, does a phenomenal job with nerve pain and muscle pain. The only side effect to worry about is sleepy. It does make you very sleepy, and it also causes some bladder issues in the elderly. Tramadol is unfortunately the FDA put it under a narcotic class. It's really not a real narcotic. Up till a few years it wasn't even a narcotic, but now all of a sudden with the whole opioid crisis it's become a narcotic. But it's worth trying it. Tramadol does have a different mechanism of action from other drugs. Duloxetine is not my favorite drug to try. It has a lot of side effects, and it's really difficult to come off this drug. It's highly recommended in the literature for treatment of neuropathic pain. If you're already on it, it's fine, but it's not something that I would start. The best thing is to do a combination of these drugs, because each one of these works differently. So if you get a little bit of this and a little bit of this, you can get the best of both. Other treatments to try is low-dose ketamine infusions. I'll talk about that. Magnesium infusions or topical magnesium. You can even try oral magnesium. So one of the things that I realize now is that we are very deficient in magnesium. My grandfather was not. The reason being that they used to eat, so your magnesium supply comes from green leafy vegetables, spinach. In those days, spinach actually had magnesium. The spinach that we get now doesn't have enough magnesium. So all our vegetables don't really have enough magnesium. So our supply of magnesium has depleted severely in our diet. And the problem with magnesium is it's not a reliable blood test. So oftentimes they'll do a blood, because magnesium lives inside the tissue. So it's not a reliable test. If you take it orally, it has its side effects, the side effect being diarrhea. So you can't get enough magnesium orally, but magnesium infusions or even topical magnesium, if you ever go on YouTube or if you go on Amazon, you can find lots of ideas on how to make or buy magnesium topical. Works beautifully well. Epsom salt bath is a classical example. Epsom salt bath is magnesium. Fill a tub with water, 2 large cups of Epsom salt, soak yourself, you feel great. And it's all because of magnesium. Alpha lipoic acid is a antioxidant, it's a free radical scavenger. It's over the counter, you can try it. Ideally, you should try it IV, but it's not available as IV in the US. So you can get it as pills. It does do a good job. N-acetylcysteine, also sold as NAC. You know how some people with neuropathic pain have a cold limb, they have cold feet, it warms it up. It's also an antioxidant. Absolutely make sure the vitamin D and calcium levels are on par. Now, again, on vitamin D, I just want to tell people this. Taking a capsule of vitamin D is not getting enough vitamin D. You need to be out in the sun, get some vitamin D from there. That's the best source of your that's how the body processes vitamin D. Unless we don't get sun, we don't process it. I can guarantee you that more than half of this audience over here is vitamin D deficient. Now, unless you don't have these basic material all set, we can't expect to treat our neuropathic pain. We can't expect our nerves to heal unless we don't have the building material. Just gave me a fright. Other drugs, carbamazepine, phenytoin, lamotrigine, these drugs have been around for a long time. We've tried them over the years. Nothing to get excited about. If it works, fine. If it doesn't work, the problem is the side effects are enormous and the risk-benefit doesn't quite support it. But, I'm not against trying them, but I wouldn't go for these drugs as a first choice. Cannabis, we don't know enough about cannabis and neuropathic pain, but we do know about cannabis and pain. We know about cannabis and sleep and appetite and nausea. We know a lot about that. So it can help with some of the pain and sleep issues and, of course, nausea. Topical cannabis does help some of the burning pain and small fiber neuropathy. So over here, I just want to briefly touch on CBD. So you have 2 kinds of CBD. You have the hemp CBD, which you can buy at literally anywhere. Now they're putting it in coffee also. So that's hemp CBD. But CBD from cannabis is different, and that is far more efficacious. So if it's possible in whichever state you live in, if it's possible, go for the cannabis CBD rather than the hemp CBD. If not, then you can always try the hemp CBD. That'll do the job also. So like I said, I'm not sure if it'll work on neuropathic pain or not, but it's worth trying it. It won't do any harm. Treatments that I would avoid are steroid injections unless there's some overlying cause, there's a definite cause, there's a joint inflammation that's triggering your neuropathic pain. That's a different story, but I'd be cautious about it. I wouldn't go for spinal cord stimulators, peripheral nerve stimulators, or this capsaicin cream. I don't know if you know what capsaicin is. It's hot chili pepper. The last thing I want is hot chili pepper on my skin. Medically, there is enough evidence. It's true. I don't make it sound light about it. Medically, yes, it depletes substance P, which then helps with pain. But there is no way a patient is going to come back to me after I give them capsaicin. There is no way. So I don't recommend it. There are 2 forms. You can buy one over the counter, and then there's a prescription, which is really strong. This is low dose naltrexone. Is one of my favorite drugs to try. In fact, one of my go-to drugs to try. Naltrexone is an old drug. It was approved some 30 years ago for the treatment of something called, none of you have it. It's called for addiction, but it's when you take it in a really tiny dose, and we'll talk about the doses, it can help with neuropathic pain. This is my first drug of first choice for neuropathic pain. It decreases fatigue. And now I'm getting reports from other physicians that it does help mast cell activation syndrome. It basically works in stabilizing the immune system. That's how it works. And so once the immune system is stabilized, then all that nerve damage that happens from these immune systems is not happening anymore. You start at 1 to 2, this is what I do, 1 to 2 milligrams in the morning for a couple of weeks, and then go up to 4.5 milligrams. You can take it either in the morning or at night, depends. Some of the initial side effects are headaches, insomnia, and colorful dreams. That's fine if you're into watching movies in your sleep. The reason I try it in the morning is because of this insomnia. And so I tell them to take it in the morning, but if once they have been on it for some time, then all this goes away actually. You've got to give it some time. It takes a few weeks to notice a difference. So in terms of treatments, I want to talk to you about two different things. One is called disease-modifying agents, and then there are the agents that are just used to manage. Disease-modifying agents are what we like because it corrects the problem. It fixes what's broken. The rest of the stuff is sort of a gateway to getting to the disease-modifying agent or modifying the disease condition. So this LDN falls into a disease-modifying drug. Try it for at least 6 months before you decide it's going to work or not. Some patients complain of really significant side effects, and it's reasonable to start at even as low as 0.5 milligrams and then go up to 1 milligram. It's made by a compounding pharmacy. Some physicians, I haven't done it often, but I've been told a lot of physicians, some physicians will go up even higher. If they don't see a response at 4.5, they'll go up to 6 milligrams or 12 milligrams. But if you see a response at 4.5 milligrams, stay there. More is not always better here. There's something called ultra low dose naltrexone that's coming up a lot now. This is, so, with low dose naltrexone, one of the things is that you can't be on opioids, okay? With ultra low dose naltrexone, now we have people saying like, okay, people on narcotics can still try ultra low dose naltrexone. The dose is 0.1 to 1 milligram. I don't know the results, but I've done it only for a few patients. I don't know the results, but nationally, in talking to other physicians who have been using it, they have shown some really good responses. So it's worth a try. IVIG, this is, again, immune dysfunction is basically your own antibodies. These antibodies are soldiers that live in our body that are part of the defense. So they fight infection. And sometimes these soldiers go haywire, they go rogue, and then they attack your own body. And so you've got to get rid of those guys. So what we do is we borrow healthy antibodies from other people and infuse them. So we are trying to kind of replace our bad antibodies with good antibodies. And that's the whole idea in doing IVIG infusions. We do see some good results with it. I don't do them, but immunologists do them, neurologists do them. We've been seeing some really positive results in patients with dysautonomia, neuropathic pain as a result of autoimmune dysfunction. And like I said, we are now starting to think that most neuropathic pain and most small fiber neuropathy is an autoimmune problem. So this is the one that I was going to talk to you about was CGRP, calcitonin gene-related peptide. It's a chemical that is produced by nerves. When the nerve gets inflamed, inflammation of the nerves, so what they've seen is when nerves get inflamed, they produce CGRP. And so CGRP levels are increased in patients with pain. And this is a really this is pretty recent. In the 1980s, they've actually discovered CGRP. And in 2018, we now have 5 drugs that work on this. That's the best news. So far, these are the 4 that have been, these 3 are in the market already. And so these are CGRP antagonists. So the idea was that, all right, so these nerves, when they get inflamed, they produce CGRP. And when the nerves are not inflamed, there's no CGRP. what if we block the effect of CGRP? And so these are the drugs. I really can't read these names, but Aimovig, Ajovy, and Emgality are the three that have come out. There's one more that's coming out. This is an oral one that's coming out. It's not yet in the market. And there's one more, I couldn't find out the name. At this time, the FDA has only approved it for migraines, and the feedback has been phenomenal. Almost no side effects, but fantastic results. It's very unusual to see a drug with hardly any side effects. There's a new one. I don't know the name yet. I have the chemical name, but it's just been approved for knee pain, to be injected into knees with arthritis, severe arthritis. My thing is, the reason I'm getting so excited about it is that, well, if it can work for migraines, which is again inflammation of the nerves and blood vessels, maybe this can work for neuropathic pain. CGRP levels do go up in patients with trigeminal neuralgia. We've seen that. It does go up in a bunch of other post-herpetic neuralgia. It does go up. So maybe these can be extrapolated at some point. The FDA will agree to, or some pharmaceutical company will do more research, and eventually it'll get approved for other neuropathic pain conditions. Ketamine. Ketamine is a drug that's between a disease-modifying and disease-managing condition. It's more disease-managing, allowing for disease-modifying conditions to work. It's a very powerful painkiller. It's used mostly in the operating rooms in the ICU. The problem with ketamine is that when you take it orally, it doesn't get absorbed. It has a very poor absorption. It works very well as an IV or sublingual or nasal. The only thing is that ketamine infusions or taking ketamine has to be done along with other therapies. So if you're doing physical therapy, other disease-modifying agents. The FDA has just recently approved ketamine nasal spray for treatment of depression. They call it treatment-resistant depression. They've just approved it finally. They've hummed and hawed over it for years, and finally they went ahead and approved it, which is kind of good news for patients with neuropathic pain, because it's not out of the norm. In the old days, when I would mention ketamine to someone, they would get, oh my God, it's a day trip drug. But now, all right, let's try it. Is this all being recorded? All right. So anyway, don't use it as a day trip drug. So ketamine given in very small doses, very, very light doses, are what's called as sub-anesthetic doses, can block these guys called NMDA receptors. There's really no other good drug that blocks NMDA receptors as ketamine does. And these guys, these NMDA receptors, are the culprits behind severe neuropathic pain. It decreases central sensitization. You remember I showed you that picture with the Smithsonian picture with the signals going up and down? It decreases central sensitization. These are rough estimates. About 85% show improvement in daily activities. Again, it is not a cure. It has to be done with other therapies. Just to give you a protocol, it's done over 10 days. It's called the loading dose. You start low, you increase it slowly, and then it has to be repeated every so often, because remember, we haven't yet fixed what's broken over here. So we haven't done that yet. So once, say you're in physical therapy, say you're trying other things, and while all that is working, you do need boosters, which is usually done every 4 to 8 weeks, depending on the patient. The problem is that I didn't talk about glial cells, but the cause of central sensitization is activation of the glial cells in the brain. Most of the side effects of ketamine, this is why I want to put this slide, is to reassure you that it's not as horrible a drug as we think it is to be. Most of the side effects are temporary and short-lived and reversible. Long-term side effects of ketamine infusions, there's no documented studies done, but I have a scientist. He's a neuroscientist. He gets it. He's doing great on it. In fact, he just got his PhD. I have an accountant. I have students who are doing fantastic in school. So it doesn't really affect cognitive functioning in the long term. Some of the side effects are nausea, vomiting, again, colorful dreams, hallucinations, and headache. These are in the higher doses. the hallucinations. Oh, thank you.